So I'm going to talk about practical tips, but I'm not going to speak for very long. I'm just going to be very brief. But one thing I would like to tell you all youngsters is uveitis is sometimes not as boring as you see. You know, you see those macrophages coming and those interleukins coming and you say, what the hell? It's probably not my cup of tea. It's not like that. And to be very honest with you, if you're not into immunology, you really don't have to know all that stuff to be a good uveitis person. I don't understand most of it and I think I'm reasonably fine with it. Okay. So what you need to know precisely is what would you do if the patient comes to you? So let's begin with TB before I show my maybe 5 or 10 slides. Patient comes, you look at it, you think it could be TB, but you cannot call it TB till the time you have ruled out all the possible differentials. That is the key, you know. So, you know, it looks like TB, but it could be toxo, it could be mutes, it could be this. Keep that in mind. Note it down in the file, you know, your thought process, love your thought process. Say, these are the 4 things I am thinking. TB will never be the first diagnosis. Okay, so you have ruled out whatever else you are thinking. Well, there are only 3 tests for TB, whatever the PCRs and Sir keeps showing, actually nobody in the world is able to replicate it. They come from our institute, but we never ordered those tests. So don't think you cannot diagnose TB till you have those fancy labs and NATs and all that, nothing. You just do 3 tests. You do Montus, you do quantiferol. WHO will keep on telling you it's banned for India, but we do it all for all practical purposes. And you do chest imaging, which is CT chest, if your patient can afford, or X-ray chest. When you are doing chest CT, look for the evidence of old Gons focus. Don't look for active disease because it's not going to be there. The next question is, now your tests have come positive, would you treat or not treat? Well, we have developed consensus guidelines by courts which very clearly tell what to treat, what not to treat. But again, when you read those reports, there is a statistical jargon there, interquartile range, median, and you get confused. So to simplify things for you guys further, we have developed an app called COTS Calculator, which is available on our IUSG website and I think on USI website also, otherwise you can just write to me. It just has 5 simple questions. You enter what is the diagnosis, like you say serpiginous choroiditis, where is the patient from? Patient is from India or London or whatever. What are the tests positive? Montus positive, X-ray not done, and quantiferon not done or negative. It just tells you whether to treat or not, making your life simpler. So now coming to my talk, which again is not good, I'm not going to talk very long, is uveitis, what do you do? Problem is people don't practice uveitis because in meetings we make uveitis seem such a complex topic that nobody probably feels motivated. And secondly, it's a disease with lots of recurrences. Patients don't get cured. It needs a multidisciplinary approach. You need a lot of paraphernalia. So, but that is only for some of the uveitis patient. By and large, you will be able to sort about, I think 60 to 70% of uveitis patients only if you declutter your mind of whatever is being taught to you. If you just, have a fresh mind, a fresh approach, and don't look at the records that patient is carrying because sometimes that can be a hell of confusion lying in those records. So first, approach the patient with open mind. This is my favorite slide. This is like a clutter of the book which is not being catalogued. Now you are looking for one particular book and you start going over the pile. So what do? You keep on looking at the pile, and that is what we do in uveitis. There is this investigation. So somebody said there is a new test, let me order that. Somebody talked about some PCR, let me try to get that. So you keep on ordering the investigations. They are like the books. Some investigations will take 2 weeks, some will take 3 weeks, some say gone to Bombay, report nahi aaya, and by the time you find the book, you may not even want that book. Your exam might be over already. You may have passed or failed. Similarly, by the time you get the results of those fancy investigations, your patient would have already, lived the course it had to live. So don't chase after those investigations for normal day-to-day patients. So what do? You declutter. You just don't think of all the tests that have ever been shown to you or taught to you. So what do? This is the approach. So first you take a very basic general history, which is nothing. What is the age? What is the gender of the child? And just the very basic. What is the race, socioeconomic status? Ask the ocular history like you would normally talk to a person. That what is the duration? Has it been recurring? Get an overall idea. Systemic history and any treatment that he has received. After that, instead of taking that entire history, just do a very comprehensive ocular exam, slit lamp mein. What are you seeing? Are you seeing granulomatous, non-granulomatous? Is there fibrin? Is there hypopion? What is it going? And then looking on that pattern, you can ask the specific history. For example, if you see if you see granulomas, mutton fat KPs, you can always ask the patient, did anybody in your family had TB? Have you ever received anti-TB drugs? But you don't have to ask every patient, HIV to nahi hai, you had sex with a prostitute, nobody is going to give you that kind of history. Unless you actually are talking about the targeted history, depending on what you have. And of course, general physical examination. This is the key word. You name the disease. In the naming, what you have to tell is, I'm just going to show the example and show you what is naming and what is meshing, and that is what uveitis is all about. Now, you have a 40-year-old man who comes to you with decreased vision in the right eye for last 4 weeks. Okay, this is all you need in the basic complaint. Patient says it is insidious onset. The moment patient says it is insidious, what Dr. Reema was showing you beautiful pictures of HLA-B27, that is out. Because HLA-B27, the patient will say कि मैं सुबह जब सो के उठा मॉर्निंग वॉक पे गया 7 बजे के करीब मुझे पेन हुआ. The moment you get that history, that is HLA. It's just by talking to the patient, you would know what you are talking about. Now, patient says he's using topical steroids 4 times a day without much relief. Now, what does it indicate you? It indicates you the person is not getting adequate amount of steroids, so that's why he's not responding. And he says there is something involving the tip of the nose. So that raises your caution. Is it herpes we are dealing with? And there is no systemic history. So these 4 liners, you just talk to the patient. Go to the slit lamp. See what kind of uveitis are you seeing. Now when you look at this slit lamp, you see there is a granulomatous inflammation. There are flare, there are cells, but there is granulomatous inflammation. I don't think this is required, but if you want to sometimes look, these are granulomas in the angle. So moral of the story is you have a patient with granulomatous anterior uveitis. What will you do? You name the disease. Now, if I have to name this 40-year male, unilateral, insidious onset, granulomatous anterior uveitis, and nasal brush. Now, there are 381 diseases which produce uveitis. Out of those 381, just think of the entities which will cause this. There won't be many. You can think of TB, you can think of sarcoid, and because of that nasal rash, it could be viral. Also think of syphilis. Syphilis we keep everywhere, so we have not added syphilis. Very simple. Check the IOP, check the corneal sensation. If IOP is normal and sensations are normal, unlikely to be viral. If IOP is raised, sensations are raised, likely to be viral, because in acute uveitis, you do not have IOP going up. Because of the ciliary body involvement, your IOP is generally low. So if IOP is high, put viral. If IOP is okay, think of TBN. So here the corneal sensations are normal, IOP is 8, and we do not see transillumination defect. So what is the differential? Within 10 minutes of examination, you know you are dealing either with TB or sarcoid. But still, you can't ignore the nasal rash. So you look at the nose of the patient. You know, the nose of the patient doesn't show what I thought would be at the tip of the nose, the Hutchinson sign and all. It's not like that. What it is, I do not know. In uveitis, you always have to say, I do not know. Call people around, call the experts, to develop a multidisciplinary approach. So I don't know what is this, but my rheumatologist would know. So we refer it to rheumatologist. And targeted history, by that time we know it's TB versus sarcoid. So we ask any history of drug fatigue. Patient says he does feel some weakness, fatigue and breathlessness on exertion. So we are still between TB and sarcoid, and we want to rule out what is happening in the nose. And it just takes about 15 minutes of clinical examination, no fancy investigations, no immunology. So what investigations now you will do? Your differential is just TB or sarcoid. Just get some molecules. If it's positive, it's TB. If it's negative, it's sarcoid. If you want chest X-ray, TB will show healed Gons focus. Sarcoid will show lymphadenopathy. That's it. No need for doing ACE levels, gallium scans, calcium. You know, all those things are not meant to be done in clinical practice. So what will you do? In 15 minutes, you start the patient on steroids, cycloplegic. You want to consult for nasal region and tell him to come back after 72 hours with only 2 investigations. And you should always have a plan. What are you going to do when the patient comes back to you with the investigations? Suppose patient says the investigation has come and then you don't know. You know, and that happens with serologies. Serologies for toxo, serologies for CMV, for TORCH, and God knows what all. We are not going to treat them, even if it is positive for CMV. So what? So this one, you are very sure what are you going to do. And 72 hours later, the patient has X-ray which shows hilar lymphadenopathy, which is more like sarcoid than TB. Our rheumatologist Aman has seen, and he says this is lupus pernio, which is involving the tip of the nose, and this is very typical for sarcoidosis. So the mystery is solved. So what do we do? By this time his vision has improved because we have given him topical steroids, anterior chamber is quiet, and within 72 hours we know it's going to be sarcoid. Now should we biopsy? Well, we have lupus pernio from where we can biopsy, and we also have those lymph nodes on the chest. Which one we choose? So that thing, first do no harm. Always go for non-invasive. Just go for the skin, and the skin biopsy shows sarcoid. So you treat not only the eye, but also the patient in general, and you just treat the patient. So I'm not going to go any further. I'm not going to talk about posterior uveitis because the session is already delayed. But I just want to tell you that make your life simple and don't make it too complicated with too much. I mean, knowledge is very good. I'm not saying don't acquire knowledge, but don't feel intimidated and inadequate to practice because you don't understand that knowledge. I do not understand most of it, it's okay. So, learn to have the practical tips. When you are in front of the patient, don't try to, put all your theoretical knowledge applicable to that patient, because patients don't come in the form of books. Each patient will be different. We are moving towards personalized medicine, so we have to learn to understand each patient. Thank you very much once again, and pleasure being here.